Dr. Shimasaki. He is president and CEO of Moleculera Labs, and we thought it would be beneficial to have him on the panel to answer some of those questions. You've heard from Dr. Leventhal, you've heard from Dr. O'Hara, and Dr. Trifiletti, so can we just do a quick round of applause for them? So, again, we'll do our best to get through these. Some of them are obvious on who should answer, and some of them I have no idea who should answer, so raise your hand if you think you might want to jump in. So, let's see. Does a general brain MRI show changes or inflammation in the basal ganglia, or is there another test that can be done to help identify that?
Maybe I should handle that as a neurologist. Right now, well, there was a very early reports of swelling of the basal ganglia. You hear that term going on. Nobody has really done this study yet to show it. You would have to compare the person to themselves to see it at all. You have to use a fancy version of MRI called quantitative MRI. We can actually measure. It could be done on MRI data to actually see this. Nobody knows for sure if this is really the case, but there's some minimal reports of this early on. It's never really surfaced in the more recent literature. It hasn't actually been studied yet, to be the truth. You can't look at any one single MRI and make a diagnosis of PANDAS on that basis. MRI is helpful in ruling out other things. For example, if you see we had a child with PANDAS-like syndrome who had white matter disease in her frontal lobe that appeared, and it turned out she had something called Alexander's disease, adult onset, which is an unusual condition that we found out through genetic analysis. So it's helpful in ruling out other things. It's helpful to look at the pituitary in cases where there are pituitary issues, which come up a lot in these patients, but not really so much. There is an experimental diagnostic test called PET scanning that's been reported. Dr. Chugani's group in Detroit uses this, has recently written a paper using that PET scanning to help diagnose between Tourette's syndrome and patients with PANDAS. But that's at a very research level, you know.
What about the SPECT scan? Will that show anything?
Well, it might. I don't know of anybody reporting that. That test is very low resolution, and we don't have good pediatric normals.
All right. Is there an alternative to IVIG if a child cannot tolerate needles in the skin and pulls it out? Are there calming agents? Is there something that can help with heightened anxiety?
Well, I mean, first of all, there is a version of IVIG now that's called subcutaneous IVIG that is much easier. You know, if a child can tolerate maybe much smaller needles every now and then. There are other immunosuppressive therapies that are oral that are just as powerful, but they have additional risk. For example, there's rituximab. That's 2 pills twice a week, 2 pills, 2 weeks apart. But it's a monstrously powerful drug that achieves some of the same effects. But I wouldn't use fear of needles as part of that decision-making process, given the severity of that med. Maybe sub-Q IVIG would be a good choice in that child.
I think also with regard to the anxiety piece, there are several other things that can be helpful for anxiety. And looking at that methylation pathway, there's certain forms of cysteine, particularly a form called Pharmanac that's been studied at Stanford and at Yale, and now a couple of other studies. They're in individually blister-packed pills, and that can be very helpful in some kids in reducing anxiety and OCD if they can tolerate it. It's a very sweet flavor. Artificially sweet flavor, unfortunately. But that can be very helpful. There are also several herbs that can be helpful. Ashwagandha is the herbal Valium, and that can be a very helpful herb to some kids. Or rhodiola is another herb that can be helpful for kids with anxiety. Also, things that increase serotonin, herbally or medication, can decrease anxiety. And then I think with regard to the immunotherapy, I certainly agree with everything Dr. T said, but also there were things, on those slides that are other lesser oral immunotherapy, herbal and alternative therapies you could consider.
This might be for Dr. Leventhal, I'm guessing here, but parent wants to know, should you punish, maybe punish should be the right word, but should you, how do you deal with a child that has behaviors that are inappropriate while they're in a flare? Like, as a parent, how do you deal with that?
tough question. Hello? I don't, this might not be on. Okay.
It's a really tough question. I think one of the things I always talk about with parents is having a plan in place ahead of time so that in the moment of the flare and the moment of the emergency, you're not trying to come up with something. It's like always best in an emergency if you know ahead of time what you're going to do. So that's the best way I can answer it, to just problem solve with the child. So when a child is in a flare, a child is not happy, hates it, and doesn't want to be there. So problem solving ahead of time, I think, is one step in helping.
If you suspect that a family member is a carrier, how do you talk to their doctor and ask for testing? Some physicians won't run labs if physical symptoms aren't present. So I think what they're asking is if you suspect that the mother or the father or a sibling is a carrier, and you go to their doctor and say, my one child has PANDAS, I think there's a carrier, and the physician says to them, well, I'm not going to test or run these labs because there's no physical, like, how do you get around that? What should you do?
Well, I mean, I consider treatment of the family part of the treatment of the child, so I just do the testing and do it myself. And
Just do the what?
I just do the testing myself and treat according to that.
Many a pediatrician, does this one work? Oh, so don't do that? Okay, sorry. I'll break it next. Many pediatricians will do the testing, and I think the first step is, as pediatricians, we should be family doctors. And if you ask, some pediatricians will do that, and if they won't, they can call me and I'll tell them to.
If a child has a remarkable response improvement to a steroid burst, say it lasts 6 weeks, but 3 months later they start slipping, what are some appropriate treatment actions knowing that long-term steroid use is not an option?
Well, short term, you could try the steroids again, but that's a kid that may well need IVIG or some other more, immodulating therapy, or possibly even plasmapheresis in very rare cases. But that would be the next step. I would go to an immunologist.
So this is for Dr. Shimasaki. Does the timing of the Cunningham Panel matter? Does it matter if they're in the flare or not in the flare? What do you recommend?
Because it's a metabolic test, so remembering what we're looking for is the elevated titers of these immunoglobulins that are directed against these neuronal antigens. So like any other metabolic test, they will wax and wane. It's not necessary that they be in a flare, but you do want them to be symptomatic because if they're no longer symptomatic, then the likelihood of seeing antibody titers are probably reduced appropriately. The other thing that's important is anything that's immune modulating, so anything that has to do with immunosuppressors, such as steroids, certainly IVIG, those will interfere with the ability to determine the proper level of these antibodies. And so generally 10 weeks or so outside of those treatments where the immune system is back in its normal state or whatever normal was at the time, the likelihood of getting a more accurate picture of that is increased.
I'm going to just follow up for a second. So if let's say that they've had IVIG or they've had medicine, are there natural remedies that children could be taking that could get in the way that they should stop taking, or no? You know, it's like, you mentioned, I don't know what they are, but Kukurum, things like that. Are there things they should stop taking?
Well, I would say, first of all, in a lot of these kids, they are so inflamed. We'll have kids on all this stuff, and they still have levels through the roof.
Okay.
So if we think that it's a problem, we'll wait after the steroids or wait after the IVIG, but several of them are still inflamed, and we don't have any problems with any of these other immunotherapies getting the testing.
Okay, great. This is for Dr. Trifiletti. What blood tests should be ordered to help with the diagnosis of the PANDAS, especially if there's no active strep throat or other obvious infection symptoms?
Well, you usually break them up into two parts. What are the triggers part, the offense part, and what's going on with the immune system, why this child in particular. So it's, depending on circumstances and what tests have been done previously. We definitely would do the testing for group-based strep, for mycoplasma, for Coxsackie A and B, usually for HHV6, another important trigger, and EBV, as well as a comprehensive look at Lyme, by whatever means we can. I usually start off with methods for tests for Lyme that are covered by insurance, hoping, knowing that those tests, if negative, might not be helpful, but if positive, are usually very helpful, because those tests are positive. Other more sensitive tests will probably be positive as well. So we start with that, including Bartonella, Babesia, Ehrlichia. That's the offensive side. I also do a pneumococcal panel. It's important to know. Now, the pneumococcal panel is very helpful if you're a child that has, there are, one thing that really wasn't mentioned here, there are quite a few kids that have culture-proven strep and yet don't make antibodies, don't seem to make much in the way. That's very important because that's abnormal, and normally you should make a decent immune response. And often kids that with that will have very low antibody responses to pneumococcus, which is closely related. It's also a form of strep. It's antigenically very similar in some respects to group-A strep. So your immune system will often show a very flat response there. I think Dr. Babulis had mentioned that in a few patients. And the other value of pneumococcus is that whether or not you are vaccinated, we can tell from that if you've had, and especially by looking at pneumococcal titers over a period of time, if you've had recurrent pneumococcal infections or if you're prone to strep, that tells us many of, pneumococcus is one of those, I didn't have time to go over this slide, but about a quarter of all pneumococcal infections, sinusitis infections are pneumococcal, another quarter is staph, and then the rest is everything, a lot of other things. So very frequently that measures chronic sinusitis. Then we look at the immune, so that's the offense part. The defense, we look at IgG, A, M, and E, all four of them, as well as IgG subclasses. And then knowing that now, depending on the situation and the history, knowing that there are metabolic issues, I usually do B12 and folate. I do always now plasma amino acids, which is something that hasn't really been talked about, which turns out to be very interesting and important because there are certain patterns that some of these kids have that emerge related to like a light form of something called maple syrup urine disease, where they have high elevated levels of certain amino acids. And in certain cases, depending on the situation, we may even do a full vitamin panel on these kids. So it's a lot of blood drawing, but that's the full thing. That's the whole thing, and then we'll tailor it down. If it's a 4-year-old child, we'll go to the bare minimum needed to make a diagnosis. But we try to cover both the infectious part of it and the immune part. This is totally different. I mean, I started my practice 5 years ago. I was looking back at it. We measured like 1/10 of what I just told you. So it's getting bigger. The blood drawing is getting broader and broader. At some point, it's got to stop. It gets it's silly after a while. But it's all help. We do it for a reason. There's we get important information about the child, and we get an important baseline. Should they flare up again, and many of these children do, a year or two later, something we have a very good baseline on the child as well. And everything I mentioned there has treatment implications, so we're not just doing it for, just to find out what the number is, but it will determine how the child is treated.
This is for Dr. Leventhal. How would you recommend that, this happens to be a daughter's college, expand her accommodations from just time and a half on tests to more specific accommodations like multiple choice, like some of the things that you talked about? How does a parent advocate for a child in college?
You need to start with a good documentation of the deficits that your child has, a good neuropsychological evaluation, and then once you get to the college level, colleges are not really required to give accommodations. They do it depending upon their policy, so that certainly when you're looking at colleges, you want to pick a college that has a good disabilities office and is open to accommodations. A lot of the colleges will say it's up to the professor, and it's up to the student to negotiate with the professor. So it's always a struggle, but you've got to start with good documentation of what has been determined are your child's needs.
Okay, thank you. This comes up a lot, so I'm going to ask this one. How long is code too long to be on antibiotics?
Sure.
There isn't too long. I mean, you know, it depends on the child. Each individual child has to be looked at, and as long as you're otherwise supporting the immune system and the GI tract, you know, you could be on them for life. But if you're doing it with no improvement, then it's too long. So you really have to look, assess, treat, reassess. If it's not working, change it up, not just continue for the sake of continuing. So I think, but the quick answer is there isn't too long.
This is interesting. I could have written this one, but I didn't. I live in an area where there are a few known PANDAS cases, including my son, within a 5-mile radius. And I'm from Duxbury, and we have about 40 kids in our town that have been diagnosed. So this is interesting to me. Are there any environmental factors, such as cranberry bogs, pollution, etc., that are being studied that can link to having an outbreak of PANDAS in the community?
Well, I mean, there are several. The Leroy cluster, there was, I can tell you, there's a huge cluster in the west side of Staten Island, which is very close to where the 9/11 dump site was. There was a big cluster of patients there. There's a cluster in North Shore of Long Island near a pollution. So there's a lot of clues that you know, are those just areas? I mean, the only way we're going to be able to establish that is by proper epidemiological studies, you know, such as, you know, you try to find these hotspots, and then you have to link each one. I don't think we're quite there at that level yet. And of course, something like that, just like with Leroy, ruffles a lot of feathers, you know, that, you know, because now you're talking, you gotta remember, that area in Leroy is upstate New York, where they're very close to the Love Canal area. I don't know if you remember that story, where there was cancer on the, you know, they're very politically sensitive, that area. So, you know, sometimes investigating these things properly is very, very difficult. And the health department is not really that interested in doing it, I think, you know, because to do it properly is very, very hard.
And expensive.
And expensive, yeah, sure, of course.
What are your thoughts around an elevated IgM mycoplasma that won't budge? Perhaps a dysregulated immune response? Is it concerning for a PANDAS child?
Well, that's a hard one. There are many children that are like that seemingly can't get rid of mycoplasma. Mycoplasma is a special type of organism. It's the smallest free living thing on the planet, you know, as far as we know. Well, if you consider viruses, they're live, but they can only live inside the cells. Mycoplasma you can grow in a dish, but they basically are bacteria that lost their cell wall. They're extremely small, and you inhale them all the time. We know this for a fact because if you try to grow cell cultures anywhere on the planet, and even with a HEPA very fancy fume hood, if you don't put antibiotics in the dish of the cell culture, you're going to get mycoplasma. They come in through the air. We're breathing it in right now, and our immune system is constantly exposed to it. So we must have a system that's able to prevent this infection. What ends up happening is it goes to the bottom of your lungs, and then it will infect your pneumocytes, and then, you know, you have an intracellular infection that can be very difficult to eliminate. You know, there are websites on mycoplasma. There are, you know, a number of experts. If anybody would like, I'd be happy to send them a review article on mycoplasma. It's kind of dense. There's a lot less written and known about it than strep, by the way, which there isn't, you know, a whole lot known. But a lot of people have thought about it. It's been proposed in a number of chronic diseases. Where do we go with this? I mean, antibiotics, there are stronger antibiotics. You start off usually with Biaxin family, or we call macrolides, that are erythromycin, azithromycin, and clarithromycin. And there's a drug that's called roxithromycin that you can get in the United Kingdom. It's even stronger. Beyond that, there's tetracyclines that can be used, clindamycin, etc. Sometimes the patients do budge. There's even a mycoplasma-specific transfer factor, or something that's actually pretty helpful too in recalcitrant cases. We don't know if that's just an immune response that doesn't get better or a true infection. I have a feeling it's a chronic infection, though. That's what I can tell. And it is a common problem in certain kids with PANDAS. And I don't really know exactly how to solve it.
I think that Dr. Shimasaki could best answer this next one. So my child has had the Cunningham Panel, and we don't know how to read it. The pediatrician doesn't know what to do with it. Is there any advice that you can offer now that it's been done? What our next steps would be?
Send them to Dr. Trifiletti. Aside from that, certainly we would be helpful to help you in any way. That's what our staff is there. We have a limited staff, but our purpose really is to help train new physicians so that they can understand what the test is actually testing for. And as was mentioned already, that PANDAS in hands is a clinical diagnosis. So the laboratory report that we provide is more of a metabolic analysis, but even in the face of maybe negative results, the clinician is the one that would decide whether or not that patient still has PANDAS in hands. Because we do not know that these 5 serological markers are the only ones. In fact, Dr. Cunningham and our groups are looking at other neurologic markers like serotonin transporters, serotonin receptors, that are also involved in being targets of autoimmunity. So we understand that the challenge you have with that is that the physician may order a test, and then they get the results and they don't know what to do with it. So our goal, and certainly with this forum and other forums, are ways in which maybe they can be connected. The PANDAS Physicians Network is another group that I guess was just launched by a group of advisors that have done that. And the goal was to try to get new physicians to be able to communicate with case studies. It is a problem, but we do spend a lot of time trying to help them at least understand what the interpreted results may mean. So they do have to be motivated. So we're happy to help you in any way we can. Again, I am not a clinician, I'm a scientist, so I don't practice medicine without a license. But what we do is try to direct them towards research studies, what we know and what we hear, and then what we're able to, such as the clinicians here, guide them to those, although I know your backlog was probably months. But there are resources in which we can do that and help you.
Thank you. This is for Dr. Leventhal. There's a couple, I'm going to bundle them in, so if you forget, just remind me. At what is the earliest age that results are legitimate in terms of having a neuropsych evaluation done? And I'll have you answer that because this is a long one.
Okay. Well, all neuropsychological tests are normed. So there are tests that go down, all the way down to infancy, but the WIPC is normed, I think it's, I think it's 2-something or 3-something. So you can, certainly preschool age children can get a good neuropsychological evaluation, and there are a lot of tests, the normed tests, that are very helpful in assessing cognitive problems and assessing pre-academic skills and developmental issues.
This is another question you're not going to like me. Okay. And it's funny, this happened in our life as well. So, how do you get a child with Lyme encephalopathy and PANDAS to actually get to the appointment to get evaluated? And it goes on. So this is a lot in one. My child has severe OCD and is extremely oppositional, defiant. It's an ordeal to get her to IVIG appointments, doctor appointments, etc., especially for return appointments. So I think there's 2 questions here. Do you recommend a child that's in an active flare to get a neuropsych at that point? And how do you get, we talked about calming agents earlier, so it's kind of redundant, but what advice do you have for this?
We'll probably work with Dr. O'Hara to calm them down a bit.
Well, generally, I think, psychotherapy, in an extreme severe flare, the value of psychotherapy is a little bit less because, it's just not going to, they're not going to be amenable to talk there. One thing you might possibly do and this may or may not work. Maybe the child would do better at home. Some of these things can be done by home infusion, or even if the general policy of the doctor, I know Dr. Mabulis likes to do it in his office. Maybe in a few situations you can relax that, if that would make it any easier for the child, you know.
One doctor said that they would consider giving a child an Ativan before.
Yeah, sure. I mean, you can do that, but I probably if he's never had it before, you probably want to do that in the office. Yeah, yeah. Every child's different. If you know, some kids activate with Benadryl, some don't. If you know something that has been worked effectively in the past for your child, and that's the one I would pick, you know. And don't pussyfoot around. Give a good dose, you know. So you know, otherwise you just get a tired, cranky child, you know. That's all.
And in terms of neuropsychological testing, I think certainly I work with a lot of children who sometimes are at moments very difficult to test, and we work it out. You know, I sort of set up a plan with a parent. Very often, once the children get there, they really have a good time, and things aren't so terrible in my office. So we work it out. But yes, it is a problem, but it's certainly a problem that can be worked with.
So I was going to answer this one, but I've heard.
Can I just say one other thing? Okay. Just in terms of my testing style, I'm really very low-keyed, and you know, I have children who in the middle of testing will just retreat to a corner and get under a blanket, and that's fine if that's what they want to do, and then they feel better, they come out. It's very low pressured, and as I said, it's individually designed.
I will just say one thing personally. My child was really bad for a while, and we did neuro testing because we didn't know he had PANDAS. And he was in a major flare, and when my husband and I sat down across from the neurologist, said, well, you're in for a ride. He'll probably have to be committed at some point. I mean, it was a terrible label. And we walked out devastated. And he was given every label. And we found out it was PANDAS, he got IVIG, he's fine. He's fine. So I do think that if your child is in a massive flare, it costs us like $5,000 for this evaluation. Think about waiting until he's a little bit more healthier, because that evaluation we just tore up because it wasn't him. So I don't know if that ever happens to you when you meet a child who's in a complete flare and can't do anything, and then they come back a year later after treatment, they're a completely different child.
Oh, definitely. I mean, I don't, if it's not working, you stop. So I certainly am not going to continue working with a child who's, can't work.
Right.
You know, I just want to say also, you know, if you see a situation where, you know, you're getting, you know, the child that's, you know, because this fluctuates from time to time, you see, you know, evaluation 1, the child gets a diagnosis of OCD. Evaluation 2, it's ADHD. Evaluation 3, it's ODD. The multiply labeled child, always think PANDAS in a situation like that. Yeah.
Yeah, the other thing is that one of the reasons why I test the same skill over several days is just for that reason, because sometimes a child can just can't do something one day and then can do it the next day.
Right. All right, this is plasmapheresis, so we're switching over. I've heard Dr. Suedo label this as I think it says the nuclear bomb treatment option, only as a last resort and with a child at risk of severe harm. But it seems that this is becoming less of a last resort.
Well, I can tell you, plasmapheresis is you know, is a very big deal in terms of treatment because it does involve basically taking your blood out, cleansing it. Your antibodies don't drop to 0, as Dr. Mabulis said. They go down a lot, though. They go down 50%, but and that can be very significant in somebody. So you would never do it on somebody that has an antibody level of 400 to begin with, because you're going to drop them into a boy or girl in the bubble situation, which is like 100 or lower. We had a lady that I was in Italy at the time at a conference, and she called me and says her gamma globulin was down to less than 100. I mean, I told her, and she says, "What do I do?" I said, "Put a mask on, stay in your room, you know, until you get IVIG." That's how bad it was. So. You got to use it carefully. The reason why it's logistically difficult to get, we can't just, IVIG, there's a lot of doctors that will do it. You could have it even done in your home, or if necessary, a lot of places. So it's logistically easy to get IVIG. Plasmapheresis has to be done in a hospital. It's a big deal. You're taking plasma out, blood out, and you're replacing it with plasma or sometimes saline, depending on how they do it. You're not only changing, there's a lot of, depending on the size of the patient, it's a machine that the thing goes into. There's a lot of dead space in that machine. There's a lot of fluid shifts that are associated with that. There are changes in clotting factors and in plasma. I guess it's, somewhat similar, I guess Dr. McDermott, to cardiopulmonary bypass. I mean, it's not something that is trivial in terms of so it's in a sense it is it's a procedure that as places get more familiar with it, it's going to be widely. What we do in New York and New Jersey, I don't know about here, they actually have the New York blood bank that comes to the hospital to do it with the machine, with people that do this full time, basically, that are, I guess, sort of like, what do they call them, bypass technicians or whatever, that know how to do this. This is a very specialized field, to know how to do plasma. So it looks like, for me, it's the goal, it's the ultimate therapy. It will probably work, if done properly, but it's actually how to get that to happen. And I think most of the major hospitals, a place like Yale, they do plasmapheresis, I'm sure, and so does Columbia. The problem is getting them to do it for PANDAS is the hard part.
Thank you. All right, I hear this time and again, and we get calls from parents across the country asking us for advice, and this is a great question. How do you treat a child with such severe OCD they can't leave the house to even get to an appointment? So how do you even get them up if they won't walk out the door?
We've examined a few kids in the car. It's very hard to do. There can be contracts that are made, there can be bribery that is done, but sometimes it just doesn't happen for quite a long period of time. And unfortunately, medical legally, as a physician, I can't treat somebody until I see them. But we will go to the car, we'll talk to you, we'll do whatever we can, but it's a big deal. It's not rare.
All right, this is for Dr. Herrick. Can you talk more on biome restoration and I think it's TSO and resetting the system?
It's not, TSO is a different form of helminth therapy, but this is, biome restoration is green beetle worm eggs. And once you get over the ick factor, it is something that many of you may want to look into. It's a way of inciting an inflammatory reaction. So it's not for somebody to take necessarily in the midst of a flare. But the idea, if you look at the book that I mentioned, Epidemic of Absence, or several theories by, for instance, William Parker at Duke, our biomes are very disturbed. And in industrialized society, we have rid ourselves of all the normal, typical germs that our bodies are meant to see. And that's not just antibiotics and antibacterial soaps, it's wearing shoes and using toilets. And that when we used to have grains in big vats and let them sit out and dry, in there were grain beetles. So we, as a species, ate this kind of stuff all the time. And the theory is that many of our autoimmune diseases, not just autism and PANDAS and Lyme, but also, asthma and allergies, are part of this industrialized society change and this lack of typical species, not parasites, not worms, but mutualists, worm eggs that are supposed to be within our systems. And so it's not a germ, it's something that you're taking once every 3 weeks to incite an immune reaction and cause the immune system to reset. And there's lots of research out there, some from Mount Sinai, certainly some from Duke, that looks at the changes in some of the immune factors that we've all been talking about, IL-10, natural killer cells, tumor necrosis factor alpha, and the positive changes in those that cause the immune system to start acting appropriately. So it's something to consider in some of our kids.
It's interesting that some of the things that, in support of that, the things that we see, the immune problems we see in kids with PANDAS are low IL-10, low levels of basophils, which would be things that exactly what a worm would boost, so maybe, it's right.
We're almost out of time, but there's some good questions, so I'm gonna cut my talk short. This is for Dr. Shimasaki. How expensive is CAM kinase testing, and how do I get it ordered?
Well, we're a non-profit organization, but not by design, which means that I have to go raise some more money, so we keep our doors open. But the purpose really is that we wanted to be able to offer these tests that Dr. Cunningham and Dr. Sweeter were using during the clinical study that were early on trying to identify these children. The entire panel, we charge $925. We do require that we get at least $425 in a deposit, and we do build the insurance for you, and we are working to try to get as much insurance maximization as possible based upon your coverage. So the particular CAM kinase assay, it is so you know a little bit, we run all of these in triplicate and duplicate, and it's a radioisotope assay in which we take human neuronal cells and we culture them like Dr. Trifiletti was talking about, and we grow them up. And then we have to take the serum and we incubate the serum on these neuronal cells because we're looking at, does the antibody stimulate a particular enzyme called CAM kinase? And the way we do that is we incorporate P32 radiolabeled isotope into this, and we measure the ability of the antibodies to incorporate this P32 radiolabeled isotope into this CAM kinase activity. And anything above baseline, which is 100, indicates the percentage that these antibodies will activate its ability to produce this enzyme activity. So you say, well, what does that mean? That particular enzyme is in the pathway of the dopamine production in the postsynaptic neurons. So what happens is if an antibody can stimulate the production of excess amounts of dopamine, you can also have other antibodies that block these receptors. So you've got excess amounts of neurotransmitters going on. So it's a long answer to just say it's very expensive, and we run a lot of them, and you can't order it by itself, although I know that there's a lot of interest in doing that. We were not able to do that. We hope to be able to do that in the future. We are just a small group of people, and just trying to keep those going. We don't have a way in which to just run that particular assay.
And this is the last one, and then I just have a few closing remarks. It's two questions, but they're similar. Are allergy shots recommended? Can allergy shots cause PANDAS symptoms? Do allergy shots cause flares in kids? There's a lot of questions around allergy shots.
Well, it would be a good question for Dr. Bouboulous, but much better than answer that. I mean, in my experience, allergy shots. Well, I mean, number one, if you have evidence on your, we get a lot of kids with high IgE levels who turn out to have nothing they're particularly allergic to. That's problem number one. Allergy shots, I think, are useful. I'm not, this is not my area, but I think they're useful if you have a limited number of things you're trying to target. If you're allergic to the world, I mean, like everything shows up very high, which happens in some kids. It's very hard to use allergy shots, but if you have a targeted number of antigens. In my experience, I don't seem to see any sort of flare-up with allergy shots, but that's just my, I'd say maybe don't.
We have had some kids with flares with allergy shots, and I think it, again, depends on your child's underlying immune system. I would agree with Dr. Trifiletti and what he said, but you're inciting a flare. I mean, by giving the allergy shot, that's what you're doing, so you have to look at where your child is. It's a controlled flare, though. So your child may well be able to handle that, and you're desensitizing them to the more severe reactions they may have in the spring or the fall or to the molds or whatever it is. So it's a balance. It's not for everybody, but it can be helpful in some kids.
Very interestingly, we've noticed, this is just research stuff, that levels of IgG and IgE in patients are inversely correlated, and very strongly so. It's as if when you give IgG to somebody, or that naturally fluctuates, you're making anti-idiotypic antibodies to Ig and lowering levels. And that might be as important as anything in terms of treating. If that's the case, maybe there are specific treatments. Rather than IVIG, there are, what's the name, that Xolair, that stuff that you use, anti-IgE antibodies that might be tried in some kids. So we're thinking about doing that, which is an interesting approach.
So can we have a round of applause for the continually to help us. Is Katie in the room? Katie, thank you for coordinating all the documents. Lisa and Ophir. There's Ophir. Ophir is the genius behind all the design work, and he's just been, thank you so much for all your help, and been making a great team, so thank you, Lisa. And is Joan and Lisa Williams in there? We have them today. And for Renee and Paula for supporting and all the marketing and all the work that they've done. So this was the crew that made this happen. So and also, as president of the New England PANDAS Association, there is a core group of us parents that are working nonstop, meeting every month, trying to figure out what to do next and how to increase awareness. And we've got a few projects that we're working on. I just want to take a minute to let you know what we're doing. There's a lot of amazing things that have been coming out in the past couple of weeks. I don't know if some of you are on Facebook and you've seen some of the studies that have been published. How many of you know about the studies that have been published? Some of you don't. So there's amazing work that has come out in the past 3 weeks, and I'm not going to get it right. Do you want to say what they are? There's the
Well, the whole Journal of Child and Adolescent Psychopharmacology that came out in October had a tremendous amount of information, and there's a great consensus paper that's in your packets that really is very helpful to take to your pediatrician or other physicians, especially if you're new to this.
And this is exciting because it's printed research in a medical journal, correct? So,
Yep.
you know, when doctors turn to and say, I don't believe it, show me the research, show me the data, now you have something. So look in your packets, this is huge. And there's a lot more that's coming out down the road, a lot that's going to help us as we advocate for our children. The challenge is there isn't a send email button to all these pediatricians. So it's not as if they're going to wake up on Monday and know, oh, this paper just came out on PANDAS. It's just, it doesn't happen. So what we're trying to do is we're building a database, and we've asked you before, if you're on Facebook again, we send out newsletters, and we're on Facebook saying, who's your doctor? Or who are the doctors that didn't believe you and shut the door? Because we're going to do a huge mailing. It's going to be an oversized postcard, and it's going to have links to all of our presentations that Dr. Suedo taught twice already for us. Every talk here is being recorded. We're going to have that. So we're going to have all the links, and we're also going to have links to all of the papers that are being published. And we're going to mail them out. We're going to do it, and so that's a big project. We're also in July, we had an event in Massachusetts, and we had Dr. Trifiletti came, Dr. Block came, we had a bunch of doctors that came, parents, therapists, psychologists, and we take them for 4 hours. We're putting together PSAs. So that if your mother-in-law doesn't believe that this is real, you can send her a link to this PSA, and Dr. Trifiletti talked about the history of stroke. This isn't new. If your school doesn't believe that this is a real problem, and we're not going to send a note out to parents saying if your child has stroke, keep them home because this is ridiculous. We have school nurses on film saying this is what a school should do to help support your child. So the PSAs are going to be vignettes focusing on different issues. It's going to take a while to do this because we're all parents and we're all working late at night while we're taking care of our kids. But there's a lot we're trying to do behind the scenes. And so I'm telling you this because we need help. We can't do it all by ourselves. And we've only been around for a year and a half. It's amazing what a short time it is that we've been together. But as our kids get sick, I have 2 boys with PANDAS and PANDAS, and there are times when I am looking at a shower. But we still have to keep this going. So some of our board members can help us, and sometimes they're just out. So it's evolving. So if you feel like you have the energy and you can help us, visit our website. It's anypanspandas.com. And send us an email and say, hey, I can help you, or I might be able to help you while my child's well, and if I need to get out, that we're fine with that. But I'm just letting you know that we definitely need help, because there's so much more we can do. And I think that's it. So we just want to thank you for coming today, and I think this was an amazing turnout, and we're really glad that you were able to come, so thank you for joining us.